My name is Ishan Ahmed, and I am an assistant professor, interventional cardiologist, and clinician educator at the University of Ottawa in Canada. It is my pleasure, on behalf of our team, to introduce our submission to the Cardio Sim Creator competition. To identify the problem, femoral arterial access was a conventional form of access for angiography until approximately 15 years ago. And in Canada now, 90% of coronary angiograms are done by the radial approach. In the US, this number has increased from approximately 16% to 60% in the past 8 years alone. However, the femoral artery cannot be avoided, and with changing technologies in cardiac interventions and cath labs, ORs, and CSICUs, there is a renewed need for safe large bore femoral access. New trainees will conventionally not be as exposed to femoral access and are at risk of increased rates of complications. Paradoxically, senior operators will be less familiar with aspects of modern-day femoral access, such as ultrasonography. A number of cardiac interventions and procedures require femoral access skills, including bypass angiography, mechanical circulatory support, CTO chip interventions, structural and peripheral interventions. It is crucial that best practices are adhered to minimize vascular complications for our patients. A number of different tools can be used to perform safe femoral access, including fluoroscopy, ultrasound visualization, triangulating the needle properly, and performing femoral angiography. However, despite a number of published papers on this topic, only 65% of trainees report being taught how to use femoral arterial access with ultrasound. We wanted to create a femoral arterial access model that allows for the development of ultrasound-guided femoral access skills, proper landmarking, recognizing anatomical variants, and using good technique for needle entry for femoral access. Existing commercial models for this exact purpose are often fairly simplistic and cost more than $5,000. Our approach to the design of a model is intended to reflect the technical complexity of all of the different procedural factors, while also being easy to construct, cost-effective, simple, replicable, as well as safe from an environmental perspective. The principal target audience is multidisciplinary. We'd like our model to be used in general cardiology, interventional cardiology, cardiac surgery, vascular surgery, ICU, interventional radiology, and neuroradiology. It can be used for those with all levels of procedural experience, including faculty as well as trainees. The model itself consists of two parts. On the left, you'll see a 3D printed model with a simulated femoral head using a tin cup, and on the right, you have a similar model, except the tubing is this time made out of rubber. The first model is 3D printed, and you can see there it is placed in a container with a tin cup to simulate the relationship of the common femoral artery with the femoral head, and is instilled in gel to obscure the nature of the anatomy. Our second model is constructed in a similar fashion, except with rubber tubing, which allows for ultrasound-guided identification of the bifurcation as well as the CFA and the adjacent femoral vein. The model with the rubber tubing allows our trainees to find the ideal site of puncture using ultrasound, practice safe distances for puncturing the femoral artery, as well as try different levels of angulation to see the drawbacks and pitfalls of different angulations. The right-sided model, which is 3D printed, will demonstrate to you whether or not a bifurcation is high or low. Dr. Derek So, the head of our cath lab, and Dr. Quentin Berry will demonstrate to you our typical setup here. You can see on the left is our 3D printed model that allows identification of different configurations of the CFA anatomy, the gel-based model on the right, and our ultrasound setup in one of our cath labs. Dr. Berry, who's one of our structural fellows, will demonstrate to you how our model is compatible with ultrasound. As you can see him scanning on the rubber tubing-based model, you can see the bifurcation clearly being visible, and we're able to bring the CFA into view. We can vary the complexity of our model using different depth of the femoral artery, as well as introducing elements of calcification. Dr. Berry will also demonstrate to you now how access can be performed using the needle. As you can see, he's using a typical femoral arterial access kit with our ultrasound, and you can see the common femoral artery there on the top part of the screen and the tenting of the artery with puncture into the vessel itself, and the vessel can now be wired. Our simulator has been used across Canada and has been used to teach over 100 trainees over the past 2 years. Several iterations have been evaluated, and we're on our 4th iteration of the model currently. For competency evaluation, trainees will typically be sent a 5-minute video on best practices for safe femoral access, and then they will, under direct observation, perform femoral arterial access in front of an educator. This checklist will be used to mark them on their process. On average, trainees will score 8 out of 10 on the femoral access checklist after watching the femoral video. 97% of our fellows were able to correctly identify a high or low bifurcation using our models. The model itself takes an hour to make. It lasts several weeks. Per unit cost is $15. It is portable and importantly provides a stress-free environment for trainees to learn. It complements our didactic as well as case-based curriculum, and we've integrated this into our general cardiology and interventional cardiology fellowship with plans to expand this to internal medicine and cardiac surgical training. Our ephemeral access team includes myself, Dr. Quinton Berry, Dr. Zanyang Chong, Renee Boudreau, Michael Foschel, and Derek So. Thank you in advance for your consideration.